Welcome to the Let's Talk Health and Care podcast series brought to you by the Integrated Care Academy at UE Bristol. We'll be diving deep into exciting research and service changes by speaking to the people directly behind them. I'm Peter Brindle. I'm a GP with a real passion for service improvement, health tech and innovation.
And I'm Mark Griffiths, Pro Vice Chancellor and sponsor for the Integrated Care Academy at UE Bristol. Welcome to Let's Talk Health and Care.
Welcome to a special on-location episode of Let's Talk Health and Care. We're here at the For All Healthy Living Centre in the Bourneville area of Weston-Super-Mare, a remarkable community hub that brings together everything from a GP surgery to a community cafe, library, children's centre and much more, all under one roof. We're joined today by Mark Graham, the Chief Executive of this wonderful Healthy Living Centre, and by Joanna Poole, who's the Director of Nursing at Weston General Hospital. We're here to find out what brought Mark and Joe together on a mission to find a different and better way to improve the health of the local people.
It's very exciting to be here today at the For All Healthy Living Centre, recording our first on-location episode. Thank you so much both to Mark and Joe for inviting us here today for this visit.
It's great you're here and you're very welcome, and I think it's symbolic of the way we started working together. You've come out to meet us rather than we have to come in and find you, and it's fantastic to do that in person, and you're so welcome. And I say welcome because it's our base ethos here is we make everybody feel welcome, and that sounds a simple thing, but it's really important for a lot of people locally. They feel welcome and safe. So you're welcome, generally.
And so as Mark said, I mean, I first visited here probably about 18 months ago, and I was really struck by what a kind of hub of vibrancy and life there was here, really on the door of the hospital. So I think we've developed our relationship since then, and we'll talk through how that's helped us to think about how we can start to bring healthcare more into the community in this kind of base.
So Joe, you mentioned that you visited here a little while ago, and what was it that struck you most about how different this environment was compared with the environment that you're, I guess, more comfortable, familiar with, Weston Hospital? And I guess the same question to you, Mark. When you visited Weston Hospital, love a bit of compare and contrast between the two different organisations that are kind of both around to try and help the health of people.
So I think a lot of the people coming here are probably frequent attenders at the hospital, and I think to see people be able to access a safe space where sometimes they might feel that a hospital is an institutionalised place, or it might not be a safe space for them. I think it just really struck me that actually for people to be able to come here as a community, and I thought, how can we bring the hospital more into this community?
Yeah, I mean, I said earlier on about the welcome bit being really important, and we work really hard at that, and we make sure that people feel safe here, because a lot of people living around here don't feel safe even in their own homes for all sorts of reasons that we probably understand and know about. The contrast with going into the hospital, I think the hospital is by nature an institution and has to be a bit like it has to be. It is very kind of like, it's kind of very structured, and it needs a degree of structure. It needs to work like that. And everybody walks around with, you can see the hierarchy when you walk into a hospital. You can see who's got white coats on, who's got blue coats on, who's got those on. We don't wear anything here at all. None of our staff wear badges, and that's a deliberate thing so that we feel like you're not talking to you, we're one of you, we're part of you. And I know that people need our badges for safety and all those sort of things, but it sets up a barrier. And what we do from the beginning is try and remove as many barriers as we possibly can, just to make people feel ordinary.
I forgot to ask earlier on, what's really important for our listeners is just, let's paint the picture of what we can see here today, and the noises and everything. Obviously, this for myself and Peter is a bit different because we're used to a very quiet recording booth. This is so different, but the vibrancy of the place and the community being here, I think trying to describe that for listeners is really important. Who wants to have a go at doing that? Mark or Joe? Just give our listeners a bit of a kind of a flavour.
From my perspective as a nurse, I think that what you see here are real people. You see real life, whereas in a hospital, you see people probably when they're most vulnerable or, at their lowest ebb. Here you see people with just as they are, and I think that's the beauty of this place. And in fact, in talking about removing badges, I drove here from the hospital with my badge, and I thought, I remembered Mark saying, so I thought I took it off. And actually, it does feel like a bit of a release to be able to walk in here and just, feel part of everybody.
Yeah, so from our point of view, I think we have two core purposes, and sometimes get the balance between the two is quite hard. So, first and foremost, we're a community hub, a place where people can come and meet. They don't have to take part in anything. They can sit in the cafe, just have a coffee and chat and meet friends. And that is a great starting place. Then they can join in some of the things that we do, which could be Tai Chi, could be exercise class. We've just started up a line dancing class, which is going down a storm apparently, which is fantastic. And then, of course, what we have on top of that, we have a number of services based in the building. So we have the GP practice, the library, social services, domestic violence, Serono. But people can come here to use those services, and they don't have to have the stigma because they're just coming into a community building. Nobody's kind of dressed up to meet them unless they go further into the building where they're going to meet kind of more professional staff in that term. So a place where people can access services more easily, because for all sorts of reasons, some of it geographical and travel, it's hard to get into services if you live here, and some of it is just psychological. Crossing a threshold into those places can be very hard for people. But here they already feel, this is my place, I feel safe here.
So we're sitting in the busy cafe here, aren't we? We're sitting at a little coffee table in the corner. There's maybe 15 other tables around us. Nearly all of them are busy. We've got a community library over to my right, and in the big foyer that looks like there's some kind of bring and buy sale or some selling going on. I can see racks of clothes, somebody choosing some baby clothes. So it really is, it's almost like a little market centre in a way, a little hub of a community here, all very busily doing things and getting on with their day. Let's move on and have a look around, and then once we've done that, we'll sit down in somewhere a little quieter and find out how it all began.
So Mark, when did you celebrate the 20 years of...
Tuesday.
So 20 years...
So actually we opened in March 2005 when we actually opened.
So happy 20th birthday then.
Thank you very much. Yeah, we had a big picnic in the park basically. We've got loads of people.
That's brilliant.
Yeah. So up here we have kind of various sized meeting rooms.
Let's go back to the beginning, Joe. You heard Mark speak at a health and wellbeing meeting some time ago. What was it about his presentation on tribal mapping that made you think, do you know what? I need to know more about this.
Well, I think what first of all drew me to Mark was I found him a very inspirational speaker. So I think because of that, I then thought I need to contact Mark outside of this. And so we caught up, didn't we? And then I learnt more about the work that Mark was doing. I visited the Healthy Living Centre, and Mark took me to his office and showed me his stakeholder board. And I was really surprised, actually, to see the number of stakeholders that Mark works day in, day out with. And most of all, surprised to see that Weston General Hospital wasn't on it. So I kind of made a point of saying that one day, through our relationship, I'd like to see the hospital and even my name on the board. So that we kind of, through that, I think I got to understand more of what Mark does. It's great. And then I think we've moved towards how do we start to bring clinical care more out into the community from the hospital? How can we use our relationship to do that?
And Mark, when Jo reached out to you and said she wanted her name on this famous stakeholder board, which I can see in front of me now, and her name is indeed on it, and at the time, as it still is now, the hospital was actually quite a little tiny spot on a very large stakeholder board. What does that tell you about how healthcare organisations typically view their role in the community and vice versa?
Yeah, it's a good question. So we've always had a relationship with primary care because we have a GP practice in the building, but less of a relationship with hospital care, acute care. And I'll be very honest with you, and actually, you may or may not know, but for about 2 years, we ran your front door service. So when you were ran a front door service that was actually not GP led, we had advanced nurse practitioners, ANPs, and we ran that service for you. So we linked it at that level, but that was more about a service and a clinical connection. And if I'm going to be very honest with you, we always found it really difficult to build a relationship with anybody in the hospital, partly because I don't mean to disrespect anybody, but I'll say it, and you can always cut it out. Managers were very NHS managery, and clinical staff were very clinical. And what we couldn't find was what I would say subhumans. And I don't mean that again disrespectfully, but I think in a clinical setting, you have very strong, clear ways of working where you've got clinical outcomes. Your training is outcome based. You've got to. I want you to be clinically trained. I want you to fix my leg. I need you to get that sorted out. In our world, it's not just about fixing things. It's about understanding relationship and how do we build on the relationships and understanding people's stories in order to help them take better care of themselves. So it's a different cultural approach. They're both important, but it's understanding we can move between both. So that was part of what that did. So my view of those systems, particularly hospital systems, they were really hard to get into and to be heard and valued. The difference was when I met with Jo, and partly because she reached out, was like, oh, I found a human. Found a human because she's got a sense of humour. She understands she's got the clinical stuff. I could see all that. And when I went to visit the hospital, Jo showed me around, and it was great because everybody knew who she was. Everybody was very respectful. But there was, again, that humanity in there, and that made a real difference. And for me, looking at the hospital system from the outside, I can really understand why it has to be the way it has to be, in terms of you've got stuff you've got to get through, massive amount of pressure on both, clinically. I understand that. We ran the GP practice here for about 10 years, and we ran 3-4 GP practices at one point. We stopped doing that just before COVID, thankfully. So I learned a lot about clinical pressure and how you have to make sure everything obviously conforms, is safe. And I used to say in all my previous jobs, don't stress, nobody's going to die. It's not the same in clinical world, is it? Every phone call, every action, somebody might die, and that is just a different level. And so I think a lot of community groups don't understand that. So this is why we have to mutually respect cultures. Yeah. It's really important, and that's what it's about. It's about mutual respect. It's not about saying we're better than you, we're just different.
Okay, so let's talk a bit more about people then, patients. You've already given some kind of examples there, but some of them obviously, for a variety of reasons, will end up attending the emergency department. Some of them more frequently than others for a variety of reasons. Can you help our listeners understand who we're talking about, what kind of patient population, and why the current system possibly isn't working for them? So I don't mind who wants to go first. I think it's a really important point for our listeners.
We've had the privilege of having some funding to really look at how we can understand the demographics in Weston, the health inequality piece. And so we've had a health equity lead called Jenny Kerridge, who is exceptional and has a brilliant connection and relationship with lots of different people across BNSSG. And I think that the work that she's done has helped us to understand who is accessing our emergency department, and what we want to get to, what our vision is how do we develop a service that is an integrated service that, one, helps us to help people that are accessing the emergency department frequently. How do we stop them doing that? But also that prevention piece. How do we stop people reaching that crisis point in the first place? And I think that's really what we're trying to do together. How do we work as a collaborative system to really look at how we prevent people reaching that crisis? And I think in Weston, we're really privileged in that it's smaller. It's smaller than somewhere like Bristol. There's less politics entwined in it, so it's easier to try and really develop a unique service that you could spread across other regions. So I think there's two different types of people that access the emergency department. That there are people that access it, real chronic users, a lot of people with mental health, drug and alcohol addiction, but across all ages. So that was quite a surprise to us, wasn't it? That we thought it was older people, because the demographic in Weston is related to older people, but actually it's not. It's across all age ranges, and we know we have a particular challenge with younger people. So I think that's our vision. There's lots of work to do together.
Do you want to add anything to that, Mark? I think what Joan said.
Yeah, I think so. There's different ways of answering this one. So I think we have to take a systems approach. So I think if we understand we're working in complexity and understand complex systems, you can't just do one thing. You have to look at where the nodes are, and you have to look at relationship in order to make a difference. So you have to take a systems approach. And I think that's newer for most people. Most people tend to take quite a linear approach, so you have to take a systems approach. So that's building relationships, understanding each other. And then if we talk about the people that are using the emergency department probably more than others, I think I have my thoughts about why that might be, but I need to talk with them and find out more about what that's about for them. But I think around here, the issues will be a combination of, is trauma. And it's become a bit of a glib word now, proper trauma-informed work that understands that there are people that live around here who've experienced trauma from a very young age, and that impacts on their physical health as well as their mental health. So they need to feel safe, and sometimes when there's nowhere else, they just need to go somewhere where they feel safe. And in a way, that's what the hospital can provide. It provides that security, and somebody will listen to them because they have to. We also know with the pressures on primary care that primary care is under-resourced and over-demanded. And it's the same within the whole health system. But that means that it's harder and harder to get appointments for people, so they have to go somewhere. Unfortunately, ED is always there. And here, geographically, it's not that far, although I would say to Joe earlier, you still have to get one bus into town and another bus out. It's still quite a while to go. So it's a combination of, that's the complexity, it's not a single factor. And then we add in all the things that we know from those people that are struggling because they can't find a service, or nobody's providing everything that, or enough for them to be able to see them as people. They don't fit. So we have some thoughts about how we might deal with that.
So the other thing that we've also learned is that some of our frequent attenders, I don't like that word, but that's unfortunately what we call people, they are lonely. You know, they live alone. So we know from our data that a number of people that frequently attend live on their own. And I think you're right, Mark. I think they go to ED because they know that somebody there will help them and listen to them. So.
Mark, through your tribal mapping work, you built trusted relationships and communities where people might not generally trust traditional healthcare services. Can you explain why trust might not be present and how it can be built and why it matters so much?
Let me just wind back about tribal mapping and nomadic working, then come to your question. So for us, it's a new way of describing what we've been doing recently. We started using the phrase tribal mapping. And the idea is that we recognise that services have pathways and ways of offering a service to local people. That's a map. But if you look at the same territory from a community or a user perspective or a patient perspective, it's the same territory, but the map's going to be different. So you look at different tribes. They've got a map, and I can't get in there because they don't want me, they don't like me, or we open all our doors all the time. So then what we do is we work with what we call our nomadic workers, who can move between the different tribes. And they're trusted in both by the service providers, but also by local people. So if you've got trust in both those places, you can start to flatten some of those bridges and build across the links across the different people. But it's really important, it's about respecting both those places. So the trusted bit, which is the bit particularly in community settings, a lot of that is just by sitting and having coffee mornings. I was over in a group this morning where they just sit and have a chat. Somebody brought his fishing rod in, they were talking about the fishing rod, but our nomadic worker is sat there just making sure the teas and the coffees and the toasts are happening. But she's trusted because she's listening to their stories and she's alongside them in a difficult time. And then when they are struggling, she can start to say, have you thought about, can we bring you in here? So the trusted bit's really important. Of course, services don't have the time to build up those relationships because your pressures to just perform and get people through the door. And that's not disrespectful, this is what you're under pressure to do. You don't have time to build trusted relationships quite the same way that we can do that here. We have the time and the space to do that. So we need to just bring those things together.
Yeah, it's a lot more transactional, particularly at hospital level.
Of course it is.
General practice level, it's a kind of less transactional, but still often quite transactional.
Yeah.
And then down at your end, relationship, trust building.
Yeah.
For the listeners, I think just describing what's on Mark's walls in terms of the relationships, ways of working, and what happens at system or systems level, I think, and that almost triumphant of approaches across Mark's office is a very spectacular display of connection points, hubs, routes, maps. And I think, again, describing it for the listeners, this kind of encircling of nomadic working around at the core what has been provided. And how that plays out, I think, again, makes it really clear about the importance of these people and their trusted roles within communities as well, which again goes back to the points about the time invested within environments. Yeah, it just really captures what I think this is all about.
Yeah, thank you. So it's about our local connections. For me, it's about working at a strategic level. So I'm about social justice and making sure people who don't get it do have access to what they're meant to have access to. So we do that here, that's what we do. But if I don't change it at a strategic level, a system level, it's not going to change. And then the way we work is just fluid across that whole way.
I think we're going to move on now to looking at what neighbourhood-based approach looks like. We've touched on this a bit already, but instead of creating a hospital-based service in a traditional sense, I think what's happened here at the For All Healthy Living Centre, you've tried and, I would say been successful, very successful. Let's not forget this is your 20th year anniversary, so congratulations again. Trying something different with a neighbourhood-based approach. Walk us through what that looks like in practice for our listeners.
I suppose what it looks like for me personally is we have a locality partnership in Weston, and there are key stakeholders that are part of that locality. And I think all of those stakeholders represent a neighbourhood or a community, and each person will have their own positives to bring to that. And we have a meeting in a few weeks' time where each of those stakeholders will be present to start to think about how do we really actually do something? How do we move forward as a neighbourhood? And what does that look like? And I think it's really exciting, actually. As I said previously, I think because Weston is that little bit smaller, it's probably easier to demonstrate how we can deliver a neighbourhood health.
I'm looking at the board. I mean, I'm quite obsessed by these boards. Sorry, Mark, I am. Sorry. But, there's the coastal communities, there's the rural communities, there's the town-based communities. That's quite unique, isn't it, in terms of as a setting of population. And I think there's something in that as well in terms of why perhaps those raw ingredients make it what it is, I guess.
Again, we have to pay attention to all of it. So like Joe, I'm quite optimistic about how we might translate this in Weston. I've been around too long. There's a slight concern in the top-down approach that's still arriving with this one. NHS England seem to be driving it in a particular way, incredibly ridiculous timetables, as they do. And my concern is we're talking about rearranging the deck chairs again. And the danger is we just rearrange the clinical deck chairs so we get more services like Serona based in communities, which is great, but that's not neighbourhood health. We've got to get underneath this, and we've got to understand what is neighbourhood health. And actually, we also start to talk about neighbourhood well-being, because we talk about health a lot, and actually what we need to be encouraging is well-being, because then we start to move in the preventative agenda. If we're going to make any change in the future, we've got to shift some resources that way, because otherwise we're going to run out of resources, quite simply.
So clearly, you're both working towards what sounds like very much a prevention agenda, how to prevent things before they get worse. So Mark, can you give us an example of how early intervention through some of these trusted relationships that we've talked about might prevent someone from becoming a frequent hospital attender, for example?
So I'll just call him Bob. Bob is a man in his late 50s, although because he lives in this area, he looks more like he's in his late 60s or 70s. There's a big differentiation how people age. He lost his wife to a brain tumour about a year and a half, 2 years ago. And actually what started happening, he started going downhill because he suddenly lost his life partner. He didn't know what to do. He started going downhill. His health started deteriorating really quickly. And he started going to ED. We managed to connect with him because somebody had one connection with him. And actually, one of the areas we work is jointly with Alliance Homes is on one of their community allotments. So we managed to get him down to the community allotment. And it turned out he had a past where he used to love growing things. And suddenly, he literally moved from looking down, moving slowly, to looking up and out. He started tending for plants, connecting to other people, not just his wife because she'd passed away, and sharing time with them. I actually saw him this morning and he was getting a fishing rod off somebody because he's going to go fishing with them. It's really hard to measure that stuff because I can't tell you whether Bob would have ended up doing 50 ED visits, but I know he's going to be using services less because he's now connected to other people. And his health is actually already improving. He's depending less on health services to manage his life. That's just one example to give you a flavour.
In my work as a GP, I see so many attendances, really, when you boil it down, due to loneliness, where people are stuck in their own home with nothing much to think about other than their own hardships, their own bad experiences and their own health issues. Yeah. And it feeds off each other, and that turns into very physical symptoms. So that's a really good example. Thanks, Mark.
So I was just going to give another example, which is something that we are about to launch with the support of Serona and Yui, I think. But essentially, it's going to be targeting our younger people who are our frequent attenders, and through the lens of social prescribing, but an enhanced social prescribing. So, for example, a bit like Bob, that the young person will be assigned somebody who they work with, and they understand what sort of activities they like doing. So it might be music or dancing or painting or something, and they'll follow that person through. So it'd be really interesting to see how this works, and I think that will also hopefully be impactful in terms of reducing the number of attendances.
That's a great example. Yeah, we're looking forward to that piece of work. Fantastic. So we always do this in our podcast episodes. We always talk about opportunities and challenges. And what are the biggest barriers do you think you've encountered in terms of trying to work more closely together? I imagine there's no barriers. I imagine it's all been amazing and fantastic, but it might be. And what makes this kind of collaboration potentially harder than what it could have been? What's your thoughts on that?
So I think some of the challenges probably have been us working together, but making sure that the strategic bit is very much that, so that we're not doing something that is either duplicating what other people are doing, but also that it's within the strategy that the BNSSG are moving forward in. That, I think that's around communication and how we're using the different forums we go to communicate that.
Just building on Joe's point to start with, I think the bit about us all working together at a strategic level and starting to experiment with things, prototyping. We used to talk about pilots all the time, didn't we? Well, the trouble with pilots is they run out of steam halfway through and nothing's left. I prefer prototyping because prototyping means you're going to build on it. For example, what's called the Healthier Together 2040 piece of work the ICB have been doing, which is concentrated on people with multiple conditions and how we can serve them better, and the cohort that's not far behind. That's been a really great joint piece of work with the acute services, primary care, voluntary sector, all working together on developing a new methodology to make that actually work. So I think when I'm at my most optimistic, and I mostly am, that collaboration across those services and valuing each other for the equal partnership. I think we don't do ourselves a service by calling ourselves the VCSE sector, voluntary sector. I think a lot of people still think we're all volunteers because that word voluntary is in there, and I think it's a bit misleading. But collaboration is really important.
For the sake of our listeners who aren't completely clear with some of the terminology we use, BNSSG stands for Bristol, North Somerset and South Gloucestershire, which is like the area of regional sort of health management and leadership. And an ICB is an integrated care board, which is the team that basically run that area. So just for those of our listeners who are not completely familiar with some of this jargon.
And just to tap into that also, Peter, the great reminder is the VCSC, which we often refer to as is the voluntary charity and social enterprise kind of community as well, of which some of those may be paid, maybe quasi-industry as well. It's not always, as Mark rightly says, about just voluntary sector. There are paid charities and organisations in there as well, and actually becoming increasingly important as we look at health population activity.
Joe, the new NHS 10-year plan talks about neighbourhoods and integrated health organisations. Do you see this as a good opportunity to scale up what you're trying to do here?
Yeah, absolutely. So all we've done to date and our vision moving forward are aligns with the 10-year plan. I think to really start to view healthcare as a community, as a neighbourhood, is absolutely what we should be doing. Because, again, going back to your board, Mark, that's somebody's life. And actually looking at that, it's such a complex web of different organisations. So how do we, as healthcare leaders, really help to break that down, to make it really understandable and simple for people, for our community, that we all live in and that we all access these services? That really, I think, is our opportunity with the 10-year plan. And I think, again, going back to the scale of Weston, the ability to do that here and to spread that wider is something that is really exciting, I think, for us to do.
I absolutely agree. I think we have that opportunity here, which is great.
Okay, so paint us a picture then. It's 2030 and everything has gone brilliantly. You've had the right funding and buy-in from different organisations, communities. What would perfect or near as perfect look like for someone living in this part of Weston from a health, care and well-being perspective?
So I think it would be an easy two-way flow between communities and services. So where we find people, we hope to create opportunities for people to be more connected, to feel more grounded, but also we've got a job to do to help people change their way they think about their well-being. So the question I always ask people is, when you're going to be a grandparent in 20, 30 years' time, how do you want to be? Do you want to be doing that from your wheelchair or your mobile buggy, or do you want to be out there being active? So what do you need to start doing in your life now? It's a different way of saying, how can you take responsibility? Because I say to people, how can you take responsibility for their health? They'll just close down on me. But that's a big piece of work we've got to do around prevention. We've got to get people to take, because they've got used to NHS taking care of them. That's what they've always been told. So we've got to say, okay, how do you want to be? So we want people in the community to be looking after themselves better, but in just a natural way, connecting better to other people, maybe sometimes around health issues. And then we just want much better access back and forward. So we can get into systems, health systems, and health systems can say, hey, we've got somebody that needs a bit of support. How do we help find that in the community? The final bit about that I'll say around social prescribing is people often talk about social prescribing, and it is a really good way forward. The trouble is they're the travel agents, and what we've got to resource is the destinations. Because we can have as many travel agents as you want, but if the travel agents to nowhere, people are going to end up on stoneless and sandy beaches.
Great point. Do you want to add anything to that, Joe?
Yeah, I would. Having worked in the hospitals for most of my career, which is 25 years now, winter seems to become most of the year nowadays. And seeing patients being cared for in corridors, or patients that are in hospital beds that have been there for months at a time, who shouldn't be there, that they have no medical reason to be there. I would love to see a time whereby that doesn't happen anymore. And I think, going back to what Mark said, our hospitals should be there to perform the clinical specialties that it should do. And so people taking responsibility for their health and well-being is absolutely where we need to get to. And the relationships we've developed and will continue to develop will help us to hopefully do that.
So Joe, you said the perfect world would be where people who don't need to be in hospital simply don't end up being there. What will that mean for how we might think of the NHS workforce of the future? Might they look different? Might they be working in different ways, different attitudes?
So I think we're already starting to think about that, certainly the nursing workforce, because we know we have vacancies in places like the community setting. So how do we start to think about rotating staff around the system in the same way that we would want to build our services? How do we start to change the culture? Because that is a cultural change. You know, nurses are very used to starting in a hospital and perhaps staying there for the rest of their career. But actually, how do we start to build that differently? I think that's really important. We're hoping to try and do that through the lens of advanced practice. I think by testing it, that's the way to move forward. So, yeah.
So, for other communities listening to this podcast episode, whether they're hospital leaders or community organisations, what would be your key message about why this kind of partnership matters? You know, this is something which has been at the nub of all our conversations so far. What would be the key messages for those?
The first thing to remember is at heart we have the same interest. We want people to live a well and healthy life. We come from slightly different angles on it. You're at the end of it where it's not working. We're hopefully at the beginning where we can change that. But we have to remember we want people. But we also want people who normally don't access that. It's the inequalities bit we've got to pay attention to. But I think in terms of what the one key message is, we've got to trust each other. We've got to build that trust through a relationship, and then we can collaborate.
So personally for me, the relationship I've developed with Mark has really opened my eyes in terms of seeing what's beyond the walls of a hospital and how we can work to provide a more boundaryless type service or care to the public. Because you can sometimes get stuck in a silo, but hence going back right to the beginning where I saw this board and I thought, gosh, the number of services and organisations, and yet the hospital is not even on it. It was very surprising. So I think advice for other people who perhaps are in my role, get out there and see what's out there, understand who the people that work in your community are and how you can work together to really improve care.
And is there a particular thing that you've learned, Mark?
That's a good question. So I was lucky to spend a bit of time with Jo. She showed me around. I also spent a whole morning in ICU in Bristol. And the one thing I learned that I was really impressed with was the genuine teamwork that went on there. And I think it's something we could learn a bit more about. The teamwork bit, where I saw on a regular basis somebody coming up and going, how can I help? How can I help? What are you doing now? What can I do to help you? And that was fantastic. And I would like to bring some of that into our work. We do it, but not as, it just seemed to be day to day. Everybody just was out there to make sure everybody was looking after one another. And that was brilliant.
Thank you both. This has been fascinating. And I have to say, probably, Peter, probably my favourite podcast. And I just think the lesson about being, back to Joe's point about being out in community and just the environment and what the sense, the feel, what's on display, the noises, really plays into kind of the conversation today. So a big thank you to yourself, Mark, obviously, and the fantastic work you do here in charge at the For All Healthy Living Centre, and to you, Joe, for your kind of work. And as you said, reaching out beyond the walls of the hospital into the community and making that connection. It's really, really powerful, and long may that continue in terms of as a model. This was the perfect setting, I think, today to discuss how healthcare happens beyond hospital walls.
And to our listeners, thanks so much for joining us to hear these two inspirational leaders building something that's so relevant to many parts of the country and beyond. If you're as inspired as we are, please subscribe to Let's Talk Health and Care on your favourite platform for more stories of health innovation.
Until then, it's goodbye from me, Mark Griffiths.
And from me, Peter Brindle. Stay healthy and take care.